Diverticulitis management. A question and answer session. Welcome to the Everything Surgery podcast. Today we do essential question and answers on the management of diverticulitis. Pause the video after each question to attempt window. Let's dive in. Section 1. Fundamentals and Pathophysiology. Question. What is the difference between diverticulosis, diverticular disease, and diverticulitis? Answer. Diverticulosis refers to the presence of outpouchings, known as diverticula, in the colon and is usually asymptomatic. Diverticular disease describes symptomatic diverticulosis, such as bleeding or pain without inflammation. Diverticulitis is the inflammation or infection of these diverticula. Question. What is the most common location for diverticulitis? Answer. The most common location for diverticulitis is the sigmoid colon, accounting for more than 95% of cases in Western populations. Question. What is the hypothesized pathophysiological mechanism leading to diverticulitis? Answer. Diverticulitis is believed to begin with a micro or macro perforation of a diverticulum, which can be caused by increased pressure within the colon, hardened fecal material, or erosion of the diverticular wall. This results in inflammation and localized infection. Question. Name 3 key risk factors for developing diverticulitis. Answer. The 3 key risk factors are a diet low in fiber, advanced age, and obesity. Other contributing factors include smoking, nonsteroidal anti-inflammatory drug use, and lack of physical activity. Question. What is complicated diverticulitis? Answer. Complicated diverticulitis refers to diverticulitis that is associated with an abscess, perforation, fistula, obstruction, or stricture. Question. What is the Hinchey classification and what are its 4 stages? Answer. The Hinchey classification is a surgical system used to assess the severity of complicated diverticulitis. Stage 1 involves a pericolic or mesenteric abscess. Stage 2 is a walled-off pelvic abscess. Stage 3 represents generalized purulent peritonitis. Stage 4 is generalized fecal peritonitis. Question. What is symptomatic uncomplicated diverticular disease? Answer. Symptomatic uncomplicated diverticular disease presents as abdominal pain, typically in the left lower quadrant, attributed to diverticula in the absence of overt inflammation. Question. What is segmental colitis associated with diverticula? Answer. Segmental colitis associated with diverticula is inflammation of the colonic mucosa between diverticula, which can mimic diverticulitis or inflammatory bowel disease during endoscopy. Question. Why is the sigmoid colon particularly susceptible to diverticula formation? Answer. The sigmoid colon is most susceptible to diverticula formation because it has the smallest diameter of any colon segment, resulting in the highest intraluminal pressure. Question. What role does chronic low-grade inflammation play in diverticular disease? Answer. Chronic low-grade inflammation is increasingly recognized as a contributor to symptom development in symptomatic uncomplicated diverticular disease and the progression to overt diverticulitis. Question. True or false? Diverticulitis is always caused by a bacterial infection. Answer. False. While bacterial invasion is a key component, the initial event is often an inflammatory perforation and not all cases demonstrate positive cultures. Question. What is the significance of the fat creeping sign on a computed tomography scan? Answer. The fat creeping sign refers to pericolic fat stranding, which is a primary computed tomography finding of acute inflammation in diverticulitis. Question. What is a giant colonic diverticulum? Answer. A giant colonic diverticulum is a rare complication larger than 4 to 5 centimeters. It may become infected, perforate, or cause obstruction. Question. How does the clinical presentation of right-sided diverticulitis differ from other types? Answer. Right-sided diverticulitis is less common and can mimic acute appendicitis, presenting with pain in the right lower quadrant. Question. What is the lifetime risk of progression from diverticulosis to diverticulitis? Answer. The lifetime risk of progression from diverticulosis to diverticulitis is approximately 4 to 5%. Section 2. Clinical presentation and diagnosis. Question. What is the classic triad of symptoms for acute diverticulitis? Answer. The classic triad includes constant pain in the left lower quadrant of the abdomen, fever, and an elevated white blood cell count. Question. What other symptoms are commonly associated with diverticulitis? Answer. Additional symptoms may include nausea, vomiting, constipation, diarrhea, loss of appetite, and occasionally urinary symptoms due to bladder irritation. Question. What are the key findings on physical examination for diverticulitis? Answer. Key findings include tenderness to palpation in the left lower quadrant, often accompanied by guarding. A palpable mass may suggest an inflammatory mass or abscess, and rebound tenderness suggests peritonitis. Question. What is the most important initial diagnostic test for diverticulitis? Answer. The most important initial diagnostic test is a contrast-enhanced computed tomography scan of the abdomen and pelvis, which is considered the gold standard for diagnosis and staging. Question. What are the classic computed tomography findings of uncomplicated diverticulitis? Answer. Classic findings include thickening of the colonic wall greater than 4 mm, pericolic fat stranding, and the presence of diverticula. Question. What computed tomography finding confirms complicated diverticulitis? Answer. Complicated diverticulitis is confirmed by the presence of an extraluminal collection of fluid or air, extraluminal contrast, or the presence of gas or contrast in the bladder, which may indicate a fistula. Question. When might ultrasound be used in the diagnosis of diverticulitis? Answer. Ultrasound can be used in young women to rule out gynecological pathology, in pregnant patients to avoid radiation exposure, or in resource-limited settings. It can reveal wall thickening, diverticula, and inflamed fat. Question. When is a plain abdominal X-ray useful in the evaluation of diverticulitis? Answer. A plain abdominal X-ray is primarily useful for ruling out bowel obstruction or free air under the diaphragm, which would indicate perforation. It is not diagnostic for diverticulitis itself. Question. What laboratory findings are typical in diverticulitis? Answer. Typical laboratory findings include an elevated white blood cell count with a left shift, and an elevated C-reactive protein, which is useful for monitoring response to treatment. Question. When should colonoscopy be avoided in the acute setting of diverticulitis? Answer. Colonoscopy should always be avoided during acute diverticulitis due to the high risk of perforation. It should be performed 6 to 8 weeks after resolution. Question. What is the purpose of colonoscopy 6 to 8 weeks after an episode of diverticulitis? Answer. The purpose is to evaluate the extent of diverticulosis, rule out underlying malignancy, and confirm healing. Question. A 45-year-old male presents with pain in the right lower quadrant. What are the top differential diagnoses? Answer. The top differential diagnoses include appendicitis, right-sided diverticulitis, infectious colitis, inflammatory bowel disease, and kidney stones. Question. A 70-year-old female presents with pain in the left lower quadrant and air in her urine. What complication does this suggest? Answer. This presentation suggests a colovesical fistula. Question. What is the Alvarado score used for, and is it applicable to diverticulitis? Answer. The Alvarado score is a scoring system used for diagnosing appendicitis. It is not used for diverticulitis. Question. How can Crohn's disease be distinguished from diverticulitis? Answer. Crohn's disease can be distinguished by a history of chronic diarrhea and weight loss, endoscopic findings such as aphthous ulcers and cobblestoning, rectal sparing, and histology showing transmural inflammation and granulomas. Question. What is cancer masquerading as diverticulitis? Answer. A colonic adenocarcinoma can cause perforation and nearby inflammation, resulting in a computed tomography scan that looks identical to diverticulitis. This is why follow-up colonoscopy is mandatory. Question. What is the role of magnetic resonance imaging in diverticulitis? Answer. Magnetic resonance imaging is excellent for diagnosing diverticulitis, especially in young patients or pregnant women, as it avoids radiation exposure and offers similar accuracy to computed tomography. Question. What is the role of a water-soluble contrast enema in diverticulitis? Answer. The use of water-soluble contrast enema is largely historical. It may show extraluminal contrast from a perforation or a stricture, but it has been replaced by computed tomography. Question. What urinary symptom might indicate irritation of the bladder by an inflamed sigmoid colon? Answer. Symptoms such as pain during urination, urgency, and frequency may indicate bladder irritation. However, true air in the urine and fecal matter in the urine are pathognomonic for a fistula. Question. What is the most common type of fistula caused by diverticulitis? Answer. The most common type of fistula is a colovesical fistula, which is a connection between the colon and bladder, particularly prevalent in males. Section 3. Management of uncomplicated diverticulitis. Question. What is the first-line treatment for a healthy patient with mild, Uncomplicated diverticulitis? Answer. First-line treatment involves outpatient management with oral antibiotics, such as metronidazole combined with a fluoroquinolone or trimethoprim sulfamethoxazole, and a clear liquid diet. Question. Why is there a shifting paradigm towards avoiding antibiotics in select cases of uncomplicated diverticulitis? Answer. Recent clinical trials have demonstrated that for immunocompetent patients with mild, uncomplicated disease, observational management without antibiotics is just as effective as antibiotic therapy in terms of recovery and complications. Question. What are the absolute indications for inpatient admission and intravenous antibiotics? Answer. Absolute indications include signs of systemic illness such as high fever, rapid heart rate, low blood pressure, inability to tolerate oral intake, severe pain requiring intravenous pain relief, compromised immune system, or failure of outpatient therapy. Question. What is a typical intravenous antibiotic regimen for inpatients? Answer. Typical regimens provide broad-spectrum coverage for gram-negative rods and anaerobes, including medications such as piperacillin tazobactam, cefepime plus metronidazole, or ceftriaxone plus metronidazole. Question. What dietary recommendations are given during the acute phase of diverticulitis? Answer. Patients are advised to start with nothing by mouth or clear liquids to rest the bowel, and then advance to a low-residue diet as symptoms improve. Question. How long is a typical course of antibiotics for diverticulitis? Answer. The typical course lasts 7 to 10 days, although duration should be determined by clinical improvement. Question. What is the role of pain management in diverticulitis? Answer. Pain management is important for patient comfort. Morphine and other opioids should be avoided as they increase intraluminal pressure. Preferred agents are acetaminophen and ketorolac. Question. Why should nonsteroidal anti-inflammatory drugs generally be avoided chronically in these patients? Answer. Chronic use of nonsteroidal anti-inflammatory drugs is a risk factor for developing diverticulitis and for bowel perforation. Question. When should a patient be considered for discharge from the hospital? Answer. Discharge can be considered when the patient is without fever, has improving pain controlled by oral medication, can tolerate a diet, and has a normalizing white blood cell count. Question. What are the follow-up instructions after an episode of diverticulitis? Answer. Patients should advance to a high-fiber diet, ensure adequate hydration, and schedule a colonoscopy in 6 to 8 weeks if one has not been performed recently. Question. What is the recurrence rate after a first episode of diverticulitis? Answer. The recurrence rate is approximately 10 to 20% after the first episode, with risk increasing after subsequent episodes. Question. Does the number of episodes dictate the need for elective surgery? Answer. No. The historical rule of surgery after 2 or 3 episodes has been abandoned. The current approach is based on severity, persistent symptoms, and patient-specific factors. Question. What lifestyle modifications are recommended for prevention of diverticulitis? Answer. Recommendations include a high-fiber diet of 25 to 35 grams per day, regular physical activity, maintaining a healthy weight, avoiding smoking, and minimizing red meat and nonsteroidal anti-inflammatory drug use. Question. Is there a role for probiotics in the management of diverticulitis? Answer. Evidence for probiotics is mixed and not robust enough for a formal recommendation. They are not harmful but are not considered standard of care. Question. What is the role of mesalamine in diverticulitis? Answer. Mesalamine has been studied for preventing recurrences and treating symptomatic uncomplicated diverticular disease due to its anti-inflammatory effect, but data is conflicting and it is not approved for this indication. Question. What is the role of rifaximin in diverticulitis? Answer. Rifaximin is a non-absorbable antibiotic used cyclically in some countries to reduce symptoms and potentially prevent recurrence in symptomatic uncomplicated diverticular disease. Question. A patient improves on outpatient antibiotics but has recurrent pain 3 days after finishing the course. What is the next step? Answer. This suggests treatment failure. The patient should be admitted for intravenous antibiotics and a computed tomography scan to rule out a developing complication. Question. How should diverticulitis be managed in an immunocompromised patient? Answer. Immunocompromised patients have a higher risk of perforation and masked symptoms. Admission, intravenous antibiotics, and surgical consultation should be considered at a lower threshold. Question. How is diverticulitis managed in a pregnant patient? Answer. Diagnosis is challenging. Magnetic resonance imaging is preferred for imaging. Conservative management with intravenous antibiotics is first line, with surgery reserved for those with peritonitis. Question. A young patient under 40 years old presents with first-time diverticulitis. Is their disease more aggressive? Answer. Historically, it was thought to be more aggressive. However, recent data suggests outcomes are similar to older patients, although there may be a higher recurrence rate. Question. When would you consider elective colectomy after an episode of uncomplicated diverticulitis? Answer. Elective colectomy may be considered after recurrent episodes that impair quality of life, after a severe episode requiring hospitalization, or in patients with persistent symptoms. Question. What is the benchmark for successful non-operative management of uncomplicated diverticulitis? Answer. Over 95% of cases resolve with medical management alone. Question. What is the most important factor in deciding between outpatient and inpatient management of diverticulitis? Answer. The clinical appearance of the patient, particularly signs of systemic toxicity or systemic inflammatory response syndrome, is the most important factor. Question. True or false? All patients with diverticulitis need a surgical consultation. Answer. False. For uncomplicated cases managed medically, surgical consultation is not routinely required. Question. What is the most common organism involved in the microbiology of diverticulitis? Answer. The most common organisms are mixed gram-negative rods, such as Escherichia coli and Klebsiella, and anaerobes, including Bacteroides and Fusobacterium. Section 4. Management of complicated diverticulitis. Question. What is the first step in managing a Hinchey stage 1 or 2 abscess? Answer. The first step is intravenous antibiotics and computed tomography-guided percutaneous drainage if the abscess is larger than 3 to 4 centimeters and accessible. Question. What is the success rate of percutaneous drainage in diverticulitis? Answer. The success rate is approximately 70 to 80%. It can be definitive treatment or serve as a bridge to elective single-stage surgery. Question. What is the indication for urgent or emergent surgery in diverticulitis? Answer. Urgent or emergent surgery is indicated for Hinchey stage 3, which is generalized purulent peritonitis, or Hinchey stage 4, which is generalized fecal peritonitis. Question. What are the two main surgical options for emergent cases of diverticulitis? Answer. The two main options are Hartmann's procedure, which involves resection of the diseased segment, and colostomy, and closure of the rectal stump, and primary anastomosis with or without proximal diverting loop ileostomy in stable patients. Question. Why is Hartmann's procedure often preferred in unstable, septic patients? Answer. Hartmann's procedure is preferred because it is faster and simpler, and avoids the risk of an anastomotic leak in a contaminated field. Question. What is the major disadvantage of the Hartmann's procedure? Answer. The major disadvantage is the need for a second major operation to reverse the colostomy, which a significant number of patients never undergo due to morbidity. Question. How is a colovesical fistula managed? Answer. Management involves elective one-stage sigmoid colectomy with resection of the fistula tract, primary closure of the bladder defect, and placement of a urinary catheter after surgery. Question. How is a colonic stricture from chronic diverticulitis managed? Answer. If the stricture causes symptoms such as obstruction, elective resection is required. Colonoscopy should first be performed to rule out malignancy. Question. A patient presents with free intraperitoneal air but is hemodynamically stable with minimal pain. What is this called and how might it be managed? Answer. This is known as a contained microperforation and may be managed non-operatively with strict nothing by mouth, intravenous antibiotics, and close observation in an intensive care unit. Question. What is laparoscopic lavage for diverticulitis? Answer. Laparoscopic lavage is a procedure in which the abdomen is irrigated laparoscopic without resecting the colon. Although it was investigated for Hinchey stage 3 cases, it is now less favored due to higher rates of reintervention compared to resection. Question. After successful non-operative management of a large abscess, when should elective surgery be scheduled? Answer. Elective surgery is typically scheduled 8 to 12 weeks later, after inflammation has resolved, to allow for a safer single-stage procedure. Question. What is the key principle behind choosing a one-stage versus II-stage procedure in the elective setting? Answer. The principle is to aim for a one-stage primary anastomosis, which requires a well-prepared bowel, no significant contamination, and a healthy, Tension-free anastomosis. Question. What preoperative preparation is needed for elective surgery in diverticulitis? Answer. Preparation includes mechanical bowel cleansing, often with oral antibiotics, preoperative counseling about ostomy risks, and medical optimization. Question. What are the advantages of a minimally invasive laparoscopic approach for elective surgery? Answer. Advantages include reduced blood loss, less postoperative pain, shorter hospital stay, and faster recovery. It is the standard approach if feasible. Question. A patient post-Hartmann's procedure is stable. When is reversal typically considered? Answer. Reversal is typically considered after 3 to 6 months, once the patient has recovered and imaging confirms a healthy, patent rectal stump. Section 5. Special scenarios and controversies. Question. What is the role of enhanced recovery after surgery pathways in elective colectomy for diverticulitis? Answer. Enhanced recovery after surgery is now standard practice, involving multimodal pain management, early ambulation, early enteral feeding, and goal-directed fluid therapy to reduce complications and length of stay. Question. A patient has recurrent symptoms after a colectomy for diverticulitis. What are you concerned about? Answer. The most common cause is a redundant sigmoid colon or diverticula proximal to the anastomosis. Other possibilities include adhesions, stricture, or misdiagnosis, such as Crohn's disease. Question. How should you approach a patient with persistent left lower quadrant pain but normal imaging and laboratory results? Answer. Consider symptomatic uncomplicated diverticular disease, segmental colitis associated with diverticula, irritable bowel syndrome, or visceral hypersensitivity. Colonoscopy is important, and treatment may include a high-fiber diet, antispasmodics, or pain-modulating medications. Question. What is the relationship between diverticulitis and colon cancer risk? Answer. An episode of diverticulitis does not increase the risk of cancer, but the inflammation can mask a cancer, which is why follow-up colonoscopy is required to rule it out. Question. How does management differ for right-sided diverticulitis? Answer. Right-sided diverticulitis is often mistaken for appendicitis but is usually managed successfully with intravenous antibiotics if uncomplicated. Surgery is reserved for cases with complications that do not respond to medical management. Question. What is the most common serious complication of percutaneous drainage in diverticulitis? Answer. The most common serious complications are bleeding or injury to adjacent organs, such as the bowel. Question. What is the most common long-term complication after surgical resection for diverticulitis? Answer. The most common long-term complication is adhesive small bowel obstruction. Question. True or false? Patients should avoid eating nuts, seeds, and popcorn. Answer. False. This is a medical myth. High-quality studies show no association between consumption of these foods and risk of diverticulitis. Question. What is the role of virtual colonoscopy in follow-up after diverticulitis? Answer. Virtual colonoscopy is an option for patients unable to tolerate a complete colonoscopy, but it is inferior because it cannot biopsy or remove polyps. Question. A patient has 3 episodes of uncomplicated diverticulitis in 1 year and is otherwise healthy. What is the next step? Answer. A detailed discussion about elective laparoscopic sigmoid colectomy should take place, as frequency and impact on quality of life are valid indications, and the risk of another episode is high. Question. What is an elective resection with primary anastomosis in diverticulitis? Answer. It is the standard elective procedure that involves removing the diseased sigmoid colon and connecting the descending colon to the upper rectum. Question. Why is it important to resect down to the proximal rectum in diverticulitis surgery? Answer. It is essential to resect down to the proximal rectum to ensure removal of all high-pressure sigmoid colon and minimize recurrence risk at the anastomosis. Question. What is an anastomotic leak and what are its signs? Answer. An anastomotic leak is a separation of the surgical connection between bowel segments. Signs include fever, rapid heart rate, peritonitis, elevated white blood cell count, and turbid output from a drain if present. Question. How is an anastomotic leak managed in diverticulitis? Answer. Management typically requires emergency reoperation, removal of the anastomosis, and creation of an encolostomy, also known as Hartmann's procedure. Question. What is the most important determinant of mortality in diverticulitis? Answer. The presence of free perforation with generalized peritonitis is the most important determinant of mortality. Question. What is the role of intravenous steroids in a flare of diverticulitis? Answer. There is no role for intravenous steroids, as they impair healing and increase the risk of perforation. Steroids are used in inflammatory bowel disease, not diverticulitis. Question. A patient with a known history of diverticulosis presents with painless, massive maroon-colored rectal bleeding. What is the management? Answer. This is diverticular hemorrhage. Management includes resuscitation, urgent colonoscopy for localization and treatment, and if unsuccessful, computed tomography angiography or angioembolization may be required. Question. How is diverticular bleeding different from diverticulitis? Answer. Diverticular bleeding is typically painless and results from erosion of a blood vessel in the neck of a diverticulum, rather than inflammation. Question. What is the most likely source of a lower gastrointestinal bleed in an elderly patient? Answer. Diverticulosis is the most common cause of lower gastrointestinal bleeding in elderly patients. Question. True or false? Diverticulitis and diverticular bleeding often occur simultaneously. Answer. False. They are distinct clinical entities and rarely happen together. Question. What is the recurrence rate after elective resection for diverticulitis? Answer. The recurrence rate is very low, approximately 1 to 10%, depending on the extent of colon removed. Question. What is the role of shared decision-making in the management of diverticulitis? Answer. Shared decision-making is crucial, particularly in elective surgery. Decisions must balance the patient's quality of life, fear of recurrence, and the risks associated with surgery and its complications. Question. What new endoscopic procedures are being investigated for diverticulitis? Answer. Experimental procedures include endoscopic diverticulitis therapy and natural orifice transluminal endoscopic surgery. Question. What is the most common error in the management of diverticulitis? Answer. The most common error is failure to perform a follow-up colonoscopy to rule out malignancy. Question. What is the key take-home message for a resident managing their first diverticulitis patient? Answer. Stage the patient with a computed tomography scan. Uncomplicated cases can often be managed as outpatients without antibiotics. Complicated cases require a multidisciplinary team. Always plan for a follow-up colonoscopy. Thanks for tuning in. If you enjoy the content, please like, share and subscribe. It's the Everything Surgery Podcast. Dissect the extraordinary.